Thank you guys very, very much. It's a pleasure to be here and chat with you about something that's very, very important, but no one likes talking about, colorectal cancer. As she said, I'm a surgical oncologist at university hospitals, so I primarily don't see people who have their first, you show up, you have an early stage, potentially curable colon or rectal cancer. I unfortunately see a lot of the folks who show up with the metastatic or the recurrent tumors. And so I would love to not have a job anymore. I would love to not have to see people if we could catch all these things early when they're treatable and curable, because when they get advanced, it's much more complicated. And so this is very near and dear to my heart. I hope to never see any of you at work. So we're going to talk a little bit about why this is important. This is what we're going to go through. We're going to go through basically what colorectal cancer is, what we know about risk factors, why it's important, how we treat it, but most importantly today, if we could take away the importance of screening. What screening is. I would love to answer any questions you have about the disease, about screening, about what that process is like, and hopefully dispel any myths or fears or concerns, because I think it's very, very important. So this is looking at you and your insides. You have about 40 feet of intestine. The last 5 feet are the large intestine. Most of that is the colon, and then the very, very end is the rectum. So the first whole long part is the small intestine, small bowel. The last 5 feet are the large intestine, the large bowel, the colon. These are all the same thing. And that is an area where there's a lot, is the most common cancer. You don't really see it as much in the small intestine, but the colon and rectum is where a lot of people get these tumors, and that's what we're here to talk about today. So what does your colon do? You eat, your body makes liters of digestive juices every single day, and your small intestine digests and absorbs all that stuff. And then when everything gets to your colon, the colon's job is to resorb all that water. There's trillions of bacteria that live in there that help you digest and do different things. And then basically turns all that food and digestive juices into stool. It sits there, and then whenever you're ready, hopefully once a day, it makes its way out. What happens is that the cells on the internal lining of the colon can turn into a cancer. That can be just because of bad luck. It can be because of genetic things. We know that there are other risk factors as far as what you eat and medical conditions and things like that that increase the risk. But these colon cancers start on the inside, on the inner lining of the colon and the rectum, and that is why screening by scopes that look inside are able to catch these things very early. You can see them when they're tiny. So what are some risk factors? As people get older, the risk of most cancers goes up as you get older, greater than 45 or 50 especially. There's a lot of studies looking at these various risk factors. We know in this country that African American race, potentially Hispanic race, are risk factors for higher rates, not only higher rates of colorectal cancer, but getting it young. You've probably seen or heard on the news different famous actors. There is like this epidemic of young people, younger than 50, getting colorectal cancer. And while minority race is a risk not only for colorectal cancer, it is for getting colorectal cancer younger. And our screening guidelines have started moving accordingly as a result of that. So we can't control those things. You can't control your age, your race, or some of your genetics, but you can control diet, physical activity. Generally speaking, high-fat, unhealthy American diets are related to colorectal cancer and other cancers. Not being active, not eating from all the food pyramid, all the healthy food groups, those things can contribute to your risk. So like we said, things you cannot change but are important to know: age, your race, and your family history. If you have family members who have had colon or rectal cancer, or certain other types of cancers, you may be at increased risk. You can't change that, but you can be aware of it. You can see your doctor. You can be very diligent about screening and reporting symptoms. Things that you can change are walking, exercise. Everyone to some degree can do some sort of exercise, eating healthy, controlling your weight, and most importantly, getting screened. Because even if you're going to develop these cancers, we want to find them when we can treat them, when we can cure them. So what are signs and symptoms? You're going to look at this and say, well, I have half these symptoms every single week. And that's part of the issue, you know. I had an upset stomach. I had some gas. Maybe I was nauseous after, a big dinner one night, whatever. Some of these, we have a lot of these symptoms, and it's easy to just ignore symptoms. But some of these are very, very concerning. So if your bowels are very, very, very irregular, if you're not having bowel movements, if your stool becomes black or red or maroon, that's unusual. Everyone has different habits, but changes in colors. And then, very importantly, if you start losing weight, you're not, everyone should lose weight. We all need to lose weight. But if you're not trying and you're losing 5, 10, 15, 20 pounds, that's concerning, for colorectal cancer, but also for other things. So if you're losing weight without trying to, your stools change in their shape or their color or something like that, it's embarrassing. No one likes to talk about that, but tell your family doctor, tell somebody. Don't ignore those kinds of things because it can be serious. And now, how do we treat it? Cancer treatment is very complex, but it's also kind of simple. So if colon cancer or rectal cancer are confined just to that organ, if it is not spread to other organs, the best thing we can do is remove it with surgery. For rectal cancer is a little bit more complicated, and we're learning new ways to bundle chemotherapy and radiation and things like that. So you may have seen on the news different studies where these people didn't need surgery because this new medicine cured the cancer. There are some instances like that, but for 90% of people, the way that we can cure, the best treatment for early colon and rectal tumors is to remove them. And the specifics of surgery depend a lot on where exactly the tumor is and have you had surgery before, but a lot of people do that with small incisions, laparoscopically or robotically. Sometimes we do it with big incisions. We do it with traditional surgery. And I'm happy to answer any questions about that afterwards as well. For patients who are at risk of the cancer coming back, if your cancer has spread to the lymph nodes or if it's spread to other organs, if it's not just localized, we use chemotherapy. Sometimes we use things called immunotherapy, which work differently but are given via IV and treat your whole body similarly. So chemotherapy is meant to kill cancer cells that are floating around in your body that could land and grow somewhere. Radiation therapy generally is not something we use for colon cancer, but it is absolutely important for rectal cancer. Compared to technology many, many years ago, I'm sure everyone has grandparents, aunts, uncles who had some sort of radiation many years ago. They are so high tech, I don't even understand what these guys talk about sometimes. They are able to identify exactly where this tumor is, blast that with radiation that sometimes completely kills the tumor, and then spare a lot of times the different side effects and collateral damage that can happen from the treatment. So the technology is getting better and better and better, and it's very, very important for certain cases. So why is this important? Colorectal cancer together is the 4th most common cause of cancer, and I think it's the 2nd leading cause of cancer death in the country. How do you want to think about this? Relative to other cancers, the outcomes are pretty good. I would say, compared to some of the other cancers we treat, that if 65%, 2/3 of people survive 5 years, that's good. But that means 1/3 of people are not making it to 5 years after they're diagnosed. 4% of people are said to develop a colorectal cancer at some point in their life. Some of those are early, some are more advanced. Last year, over 150,000 cases and over 50,000 deaths from colorectal cancer across the country. So this is a big, big deal, and we have treatment options, but it is still a very big deal for a lot of people. Now, why is screening important? The 2 biggest things about screening. One, if you present with a big, bleeding cancer that is spread, our treatment options are limited. But if you are found on screening to have an early cancer that is not spread anywhere, we can cure it with surgery. We can get it all out. And your chance of doing well and not dealing with it long term are very, very good. So the first important thing about screening is that we can catch cancers early. The second thing is that, different from mammograms for breast cancer or blood tests for other things, colonoscopies actually prevent colon cancer. So the way a colon cancer develops is that you first develop a little polyp, and it starts becoming unusual. The cells get unusual, they start changing, and then they start invading. That process happens over 10 years. When you get a colonoscopy, the gastroenterologist with the scope removes any polyps that they see. So not all of them, but some of those will go on to become cancers. And there's studies that have shown that if you take one group of people who get their colonoscopies and one group who don't, the rate of cancer can be as low as half that in the colonoscopy group. So we can actually prevent colorectal cancer by getting colonoscopy screenings. The guidelines have been changing, so now different groups say different things, but the most commonly accepted guideline is that starting at age 45 for average risk patients, no family history, no symptoms, nothing else. Starting at age 45, you can do your colorectal cancer screening. There's a variety of ways we can do that. We'll go through some slides here in a bit. And what's most important is that you have to talk to your doctor. So that 45 is for everybody, but you should also start screening 10 years earlier than the age of any family member who had colon cancer. So if you had a parent or grandparent with colorectal cancer at age 50, you should start at age 40. If your parent had colorectal cancer at 45, you should start at 35. So 45 is the general recommendation, but everyone should speak with their doc specifically about their risk factors and their situation. So we'll go through the different tests for screening. They start with the less invasive, easier to do, but also a little bit less accurate, and they go up to the more invasive colonoscopy, but that's also the most effective and the most accurate, and where we often are going to end up. So you can do stool tests. You can send stool samples in, and we'll go through how that works. It's funny, something to talk about while we're eating lunch, but that's something you can do at home. You can send your sample in via the mail. You don't have to see anybody. No one has to do any invasive exam on you. And if it's negative, that's great. But if it has a finding, that doesn't mean necessarily you have cancer. And that also, if it's positive, we don't know what to do about it. That would then mean you would go get the colonoscopy. So it's more of a first test, but something you can do with the ease and comfort of your own house. So what you do is you basically collect a stool sample, you send it into the lab, and they come back and tell you, is it totally normal, or is there something concerning we should look at further? These tests will not absolutely diagnose cancer. They just tell you, you should get this looked at more deeply. But it is, again, something you can do at home. It's recommended you do it more frequently. Colonoscopies, they say every 10 years. Some of these other tests you should do more frequently because they're a little bit less accurate generally. The most invasive thing is a colonoscopy, and this is, no one wants to do this. I've argued with my parents, with my wife's parents. No one wants this. This is ridiculous. I refuse. I don't want to do it. It's embarrassing. It's uncomfortable. And in the end of the day, it's really not that bad. The worst part people complain about is the prep. You have to drink a bunch of Gatorade or water or whatever with Miralax in it, and you have all these watery bowel movements, and it's unpleasant, and your belly hurts. But then you have the procedure, and then it's done. And that's really it. And so I'm sure everyone in this room has had a stomach bug at some point. You've had diarrhea. It's miserable. I wouldn't recommend it. But it's also, if you could cure or catch early a cancer that's treatable, how much of a sacrifice is that? So I would absolutely encourage you to, it's like getting shots that hurt or anything like that. It's not a surgery. You go to sleep. Some people don't remember it because of the anesthesia. Some people kind of remember it, but it's not like you're having some wide awake, uncomfortable procedure. You are out. You shouldn't remember any of it. And if you do the prep appropriately and the procedure is successful, the doctor can see all of your colon, the entire inside of it. They remove anything that looks unusual. They can biopsy it. And after they get those results, they can tell you what is needed. Do you do this again in 10 years? Should you come back in 5 years or 3 years? Or heaven forbid, did we find something that we're going to need to work on. We can also do what's called a flexible sigmoidoscopy. This is kind of like part of a colonoscopy. You don't need all the sedation. You don't need quite the same amount of prep. It's where they use the scope and go in just the first couple of feet of your colon, where a lot of these cancers develop. This is an in-office procedure. You don't necessarily need the same amount of anesthesia. I don't know if this is quite as common. I would probably recommend just the colonoscopy. If you're going to do it, go big or go home, I suppose. So get your screenings, but then what can you do? Well, everyone has been told smoking leads to all sorts of things. Smoking increases your colorectal cancer risk. So if you smoke, do your best to quit. Not only eating healthy, but eating vegetables. So the American diet is a lot of fat and not a lot of fiber. What that leads to is a lot of inflammation and constipation and things that irritate your colon. So decreasing fat, decreasing the high sugar factory processed stuff, and putting more fiber in there, whether it's vegetables, whether it's things like Metamucil or Citracel or fibers, that improves the general health on the inside of your colon. And not only does it reduce this risk, it can improve diabetes, it can improve obesity, it can improve heart disease, all sorts of other things. And then be active as much as you can. Walk, run, play sports, just get outside, for the months that we have it where it's nice, absolutely, get outside. And then try and maintain a healthy weight, control your other medical comorbidities, all things in moderation. Every few years there's a study that says that wine does or does not cure heart disease, does or does not cure cancer. Try not to get lost in all of that. Alcohol, too much of it can contribute to your risk of colorectal cancer. Having a beer every now and then doesn't. So don't get caught up in the hype with any new studies that come up. Be responsible, all things in moderation, and then get screened. And that's all I have at this point. Any questions?
So the Cologuard, it's worth it to do?
If you were going to decide between a Cologuard and a colonoscopy, I would say the colonoscopy. If the choice is Cologuard or nothing, do the Cologuard, absolutely.
But I mean for someone that's 44, so you recommend at 45. So someone 40, 41, 42, they can do a Cologuard and before you need a colonoscopy.
Sure. And if you have a finding, and I guess the thing to remember too about these things is this is for screening, which means no symptoms. If you have blood in your stool, the bowel movement issues, if you have some concerning symptoms, then we're not talking about screening, we're talking about diagnosing a problem. So if you're 40 and you're worried that there's something going on because of some symptoms, go see your doctor. That's something that needs to be looked into. If you have no symptoms, you're feeling great, doing well, but want to screen, want to catch things early, then that would be the opportunity there.
I don't know if I missed this or not, but you said something about colon. What's the rectal part?
The rectum is the last not quite foot of your colon. So if we look at the pictures, so your small intestine is all that spaghetti in the middle. You have about 30 feet of small intestine that go from your stomach to your large intestine, your colon, your large bowel. Your large intestine starts in your bottom right over here, and it wraps all the way around. That's all your colon. That bottom part, that foot or so, is your rectum. The rectum is basically a reservoir. The rectum is the reason that we can wait and have a bowel movement when we want to. The colon is a very functional part that absorbs water and moves things along. The rectum is just a storage space, and it's the last foot or so of your large intestine. Great question. We are all guilty of using 1,000 different words, and people walk out of the office and have no idea what we're talking about. Lesions, nodules, masses, this and that. If you have that question, if you're talking to a doctor and this is confusing, have them nail it down. Ask that question. That's because it is confusing.
So do you think we should cut back on barbecue food?
I have a buddy from Alabama who says all things in moderation, including moderation. So eat barbecue. I wouldn't eat it every day. And I would make sure, if you eat a rack of ribs, maybe have a salad, just get that fiber in there. Everything is healthy in reasonable doses as far as food goes.
Yes, before the cancer or the polyps, start to develop or metastasize to other organs in the body, what type of treatment is available?
So when you have a cancer but it's localized, so it depends. For colon cancer currently, so if a cancer is in that first 4 feet and it's in your colon, the first treatment is surgery. We get it out, we look at the lymph nodes, we look at the tumor, we do analyses of the tumor, and based on that information, we would recommend whether you do or do not need chemotherapy after surgery. But the first treatment for a colon cancer is surgery. Rectal cancer is really evolving. So it used to be just surgery. Then for years it was radiation and then surgery for many patients. Now, where there's a new approach that is really gaining a lot of traction, is very, very successful, called total neoadjuvant therapy, which, without getting into all the details, a lot of centers like ours for rectal cancers are starting off with radiation and then chemo, and maybe a quarter of those patients never ever need the surgery, which it's a big surgery and it's a big lifestyle adjustment, and so if you need the surgery, you should do it. I'm a firm believer in surgery. But we are starting to learn and figure out that maybe a quarter, a third of patients with rectal cancer don't actually need the surgery. We can potentially cure it with radiation, chemo, and then very, very, very close monitoring. So
is surgery removing part of the colon, or is it just removing the polyps that's in the colon?
it is, so in a colonoscopy, when you have a colonoscopy and they see a polyp, they remove the polyp. If there is a cancer, then the treatment is to remove that segment of the colon or rectum. And the reason we do that is because there are 4 or 5 major arteries that supply each segment of your colon and rectum. Along those arteries are all the lymph nodes. So when we do a cancer surgery, we have to remove that segment of colon and all those lymph nodes so that we can know exactly how much cancer you have, what the stage is, and what the best treatment is.
Is that constitute a
Generally, no. So when we remove part of the colon, electively, we're planning on this, it's not an emergency situation, generally, no. Sometimes for rectal cancers, depending on how it's treated and that sort of thing, you may get a temporary ostomy that then they plan to close that. The ostomies more often these days are going to be if someone presents in a very emergent situation, there's bad infections, there's other problems going on, that's the safest way to get through that episode.
That's because it's so small. That way it's different because it's not as long as a colon, it's just a small portion.
No, the ostomy, we try our best not to use ostomies, but when we do, it's for very, very specific reasons. So it's based on, again, usually it's going to be for rectal cancer, or it's going to be for people who present with emergent situations where it's not safe to reconnect the 2 ends because of risk of leaking or something like that. But those are very, very specific circumstances.
So, my dad had a stage 0, I think when he was like 62. So stage 0, what process is that? Like, on the first screening, is that a polyp? Like,
I would assume that that is a polyp with cancer cells on the lining that have not started to invade. So they would call that cancer in situ, stage 0, where there are cancer cells, and if you gave them time, they would invade, but they hadn't started doing that, so we don't call it an invasive cancer just yet.
procedure to take care of that? Is
Yeah.
Does that constitute like me having a higher history?
I would think so, whatever age he is, and it sounds like 60s, I would think so. Yeah. Yeah, if he had a cancer in situ, I would say yes.
Do some people or some countries where they don't go under on colonoscopy and it's absolutely positive you have to go under?
You get like a sedation, a light, like relaxing type medicine.
Is it painful uncomfortable?
It'll be pretty uncomfortable if you would imagine kind of the worst gas pain you've ever had in your life. It's not super pleasant. You could probably do it awake. It would be if you could tolerate the discomfort. But I think pretty much across the board, we give like a light sedation. You're not intubated. It's not general anesthesia for most people. I'm not sure. I've never done it on someone awake. I might be able to do it, but it might be kind of uncomfortable. Okay, thank you very much. I'll hang around in the back. Feel free to come up and ask any questions or a little sensitive or whatever.
Good afternoon, everybody. I'm gonna start slow so that people have time to actually grab a seat. So I was debating whether or not bring slides in more formal, more informal. But I figured prostate cancer is such a topic that everybody talks, right? I figured we can have a nice conversation. You can stop me anytime. If I address one point, we can do it at the end also. But feel free to stop me anytime, and we can address a point or two. But the goal is for the next, 20, 30 minutes or so, 20 minutes, talk about prostate cancer. The reason why we talked about it is because, as you know, it's not working? All right, so let's see if we...
There is no internal mic. That's just recording purposes, so you have to listen.
So I just speak louder?
Yep.
How about that? All right, so I'll use my internal mic. Can you hear me better now if I speak like this? Is that okay? Okay, cool. So as you know, so let's go back to the basics. So prostate gland, only men has it. So women don't have it, men has it. Where is it? It's below the bladder. It has about the size of a walnut. Okay, so a little bit smaller than your closed hand, And the importance of that is because the urethra that takes your urine that comes from the bladder, it goes inside the prostate. So anything that happens to that walnut, to that prostate gland, will mess up the way you urinate when you go to the bathroom. Okay, so that's where it is. That's what's located. When there's something wrong about it, you can have things going on that's, in the prostate that are not cancer. For example, your prostate can get larger, right? It can get larger, it can squeeze the urethra, and you have problems going to the bathroom, right? Going to the restroom and you cannot pee. Okay, so that doesn't mean it's cancer. If you see a little bit of blood, you can see blood because it's coming from the bladder. That doesn't mean it's cancer. But those are signs that make you think, something might be going on here. So we will talk a little bit more today about cancer in the prostate, but I just want you to know that a lot of symptoms might be cancer, but might mean something else. So that's the location. And the reason why we're here today is because, again, it's the most common type of cancer in men if you exclude the we call it tumors or cancers are not really, some debate whether or not the skin ones, right? Not melanoma, but the other skin tumors that we go to dermatology and we remove them. If you exclude those type of tumors, prostate cancer is the most common cancer in men. That's why we're here, right? And actually it's the second most common cause of death by cancer in the United States. So we have about, close to 290,000 people diagnosed with prostate cancer. And we have, not close to 40,000 patients who are unfortunately passing away from prostate cancer. So it's a big, big deal, right? So that's why we're talking about this today. So we're walking around, and what might make us think that, oh gosh, I need to find help. I need to see what's going on, right? So in general, we call everything that's under the term of lower tract urinary symptoms. So things like your stream is not strong enough, it's weak, or it's intermittent. You go to the restroom, you stay there, you pee for a little bit, then it stops, it goes back again. Other people will feel like, oh my God, now I'm waking up 4 times a night. And I wasn't 5 years ago, right? So that we call that nocturia, meaning you go to the restroom more often. That's another sign, right? Or you're saying, Doc, I want to go to the restroom. I'm there, I'm waiting. I cannot do anything. It takes me longer to do it, right? I got to wait a minute. I got to wait 2-3 minutes. So that's another sign. Again, all these symptoms that I'm describing to you, that don't mean necessarily cancer. So I don't want to scare everybody out that is hearing us like, oh my God, I have that. I don't want to raise my hand because I might feel that. That doesn't mean it's cancer, but it does mean that, we should talk about a provider about that. Who is the people you talk to? In general, there are two specialties you should talk to. If you like your primary care doctor, that's a good way to start. You can bring it up. Hey, doc, this is going on. Can you help me with it? So that's one. The other one, there's also a good, probably the person who's going to help you the most, is going to call urologists, right? A lot of us know them as surgeons, but they do a lot more than just surgery. They actually handle everything in relation to the bladder and the prostate, okay? So those two specialties, urology and or primary care doctor to begin with. Okay, so what usually happens? Well, if you go to the primary care doctor, a lot of times, because they're not, they don't dedicate their lives just to check what's going on in the prostate and the bladder, so a lot of times what happens, they might tell you something about the PSA, which we'll talk in a second, right? And then they get a number, and they'll explain, hey, this number is high, let me send you to urology, and urology will take it from here. But some of you guys might already have urology on board, and then how does that go? So the way it goes is like this. So prostate produces something in the blood that's unique of the prostate. Nothing else in your body produces. That's called PSA, right? That stands for prostate-specific antigen. It's produced by the prostate. It leaks by the prostate. So, as you can imagine, you know, we have an idea how much is a normal PSA. And by the way, we always say all the time, there's no such thing as a normal PSA. What we mean by that is because if I have a large prostate, my PSA will be larger. It's not cancer. But why? Because larger prostate leaks more PSA. Smaller prostate might leak less PSA. But in general, the higher PSA that we get, the more likely is for us to get cancer in the prostate. And that's why we mentioned something about, well, do you have a normal PSA or, you know, or an enlarged PSA or not? So we usually quote, or back in the days, we usually say a PSA lower than 4 is what you would expect. But in reality, it's not totally true. Because if my PSA is 3.5, I'm going to be in trouble, right? Because I'm young. So when we do this, what we call age-adjusted PSA, you know, for men in the 40s, 30s, 40s, you want to see your PSA below 2, 2.5. If you have in the 50s, 60s, you were expecting then your PSA will be higher. So just take that with a grain of salt, meaning there's no law. If you have your PSA being 4.1, that doesn't mean you are in trouble compared to a PSA of 3.1, for example. So that's what I'm trying to do. But, you know, when you get the blood test, again, it's a very simple blood test. And one important thing about it is, you know, when you talk about your doctor about it and say, okay, let's get it done, you can actually get it done in a lot of places. Actually, good news for you, apparently there's free screening available to you guys, you know, to get PSA done here. So that's actually great, right? And you can have different free screening programs. And why do we do that? Well, we do that because we can actually change lives by doing so. As anything else, we heard about colorectal, we can heard about a lot of other things, and I think it's common sense. We want to find out things when they're early, when it's not too late. So that's what I'm going to spend a little bit more in the next few minutes, is explaining what that means, too late, not too late. Okay, so let's get back to urology. So you were engaged with urology. Let's say you found a PSA will be higher. Your doctor told you, well, you know, your number is not as low as I thought. Let's get you a urologist. What urologist is going to do a couple of things. Number one, you have access to the prostate gland. How do you do it? With a finger. So it's not pleasant, but it's okay. We call it a digital rectal exam. So as part of the physical exam, urology will tell you, hey, listen, let me feel the prostate gland because it's, you know, is right there by the rectum, right? In front of the rectum, it's below the bladder. I can actually feel the posterior portion, the portion behind of the prostate gland. I can feel it. Why is that important? Because sometimes you'll find a nodule there or some dull area. So that's usually one of the first things. Urology will tell you, I think I should do this. And you know why that's being done, and that's okay. The second thing that you can do, and your doctor might ask you, is, you know what, let's check how is your stream, right? You're telling me that you're waking more often at night, or during the day you're going more often to the restroom, or you're drinking the same amount of water. Okay, I get that. Let's figure out how much urine stays in the bladder and cannot pass through the prostate. So that kind of tests, stream tests, we call it different things. The special urine tests is something we can do to figure out, you know, what's going on in the prostate. And we haven't even done any tests to find out if it's large, if it's big, if it's small, but that's another test that can be done, right? The other one that can also be done, in addition to the PSA, is actually in the urine. You collect a urine sample. Why do you do that? Well, you can look for things like blood in the urine, right? So it's not as common to find blood because of prostate cancer. That sometimes in the bladder, we can get blood in the urine, as well as kidney. Kidney cancer can actually give you blood in urine. So if you see blood in your urine, you definitely need to bring it up to your provider, whether it's your primary care doctor or you're already engaged with urology. Hey, doc, I see a little bit of blood. I think you should know about it. Very, very, very important. Okay. So your doctor did that, did some of those tests. He actually hasn't seen the prostate gland yet, right? So that's the next step. So he felt it and said, well, you know, I don't find anything wrong, but we have to look at that. So in back in the days, we used to do an ultrasound. Easy test, right? We got an ultrasound and we see it. We got way better now. So today, we should think of an MRI of the prostate. And that's the first step that sometimes scares people. Why? Well, you know, because you go inside a tunnel and you stay there for like 20, 25 minutes and it's very, very loud, right? They give you some headphones, but it's still loud. You know, I had a few myself, and it was like actually scary. It's quite, I felt embarrassed. I almost like if they give you a button to push. You know, you push if you're kind of scary of being in that tunnel, right? And I almost pushing. This is a true story. I almost pushed like I think they forgot about me here because it's super loud. It's almost like the machine is going to explode any second. So I wish a provider would have told me that. And I am a provider. We prescribe tests to people all the time, but we've never got them. So it's a big deal. So I started explaining that to patients. I say, hey, listen, just be prepared. It's okay to feel like they forgot about you and they're exiting the building. The bill by bill go, because that's exactly what you might feel. So anyway, that's an MRI. Why would we do that? It's the best scan to look at the prostate gland. So you do a pelvic scan, but it's really looking at the prostate. We call that MRI of the prostate. That is so important scan. Why? It's an important scan for two reasons. Reason number one, when you get the MRI of the prostate, you can find out if there's a suspicion for cancer, yes or no. So back in the days, you say, well, a higher PSA than normal, your ultrasound, I'm not too sure, let's biopsy it. That's what we used to do. But now, if you get the MRI of the prostate, you can say, hey, relax. You say, I don't need a biopsy on you. Why? Because I have the MRI of the prostate showing me that it's reassuring. I don't need to worry about biopsying you. So that's the first reason why we do it. The second reason why we do the MRI of the prostate is because if you find a spot, a nodule, it will give me a good idea where it is, because I can see it. So when you go with the biopsy, which is usually the next step after the scan, we sample the prostate gland, right? But you're also going to sample the nodule that you see in the MRI. So we call that an MRI guided biopsy, also known as fusion biopsy. So that changed. This is actually quite recent, the last 3-4 years or so. There's some doctors out there who are still not doing the MRI of the prostate, but it's a good idea to ask for it before getting the biopsy done, okay? So the MRI of the prostate gives you a sense of the size of the prostate. It can also give you the sense of the structure of the prostate and say, oh boy, there's a nodule here, or there's nothing. You don't have something that makes me think you have cancer. Make sense so far? Okay. So you get the MRI, and then your doctor says, you know what? There's a nodule here that we got to do something about. And so with that, then we go with a biopsy. Why do you sample the entire prostate? And you do that how? You lay down in a bed, you know, and they give you local anesthesia. You know, it's uncomfortable, but it's not very, very painful, in fact. You know, I've seen many of them, many of them. And the way you do it, ideally, is with the MRI, so you know exactly where you're going after. And then the results come back. So what is that? What is cancer? So cancer in the prostate means the cells inside the prostate start replicate faster than normal and have the ability to go to other places in the body. That's what cancer is, right? Most of the patients in the United States, about 3 out of 4 people, are found with localized prostate cancer. What does that mean? That means that if I see cancer, it's going to be in the prostate, nowhere else, okay? So those are the numbers, up to, you know, about up to 3 out of 4 people. So and why is that? Well, because part of that is because we have those tools available to us. We have the PSA, we have the MRI, then we have the biopsy, and so those are the numbers for you to know. Not everybody though, you know. We have the rest of the people can present with locally advanced, meaning the cancer already left the prostate and went to other places, usually lymph nodes first, and or distant sites of disease. So some patients, and that's the term, I'm bringing that up, although it can be applicable to any cancer, when you see a spot in the bone and you have prostate cancer, it doesn't mean that you have sarcoma and prostate cancer. It is prostate cancer in the bone. So we call that a metastasis. Okay? If you see a spot in the lung, for example, that's not lung cancer and prostate cancer, that's prostate cancer in the lung. So we always follow the term, where did the cancer started? And it's cancer because it has the ability to leave where it started and go to other places in the body. The goal is not to get there. That's why screening is so important. That's why bringing those symptoms to your doctor, talking about them, is so important. And then getting engaged with urology is so important, right? So we talked about the numbers, the stats, right? We talked about the screening. We talked about how we diagnose it. Okay. There's one last thing I want to bring up shortly, and then I'm happy to expand on whatever you'd like me to expand, which has to do with, okay, how do we manage it? So you were found with prostate cancer, meaning cancer in the prostate. How do you treat it? The good news is some of these cancers won't bother us. And that's a good thing, which is kind of odd. Well, what do you mean? It's cancer. It's concerning. Well, relax. Not so much. It depends. That's why you need to know what type of cancer you have. So let me explain that further. So prostate cancer is very heterogeneous. So there are some cancers that are really, how I call it, badass. There's something that we use to know if they're badass. It's called Gleason. So most people, or a lot of people, have heard of the numbers. Oh, I have a 5 plus 4, or a 4 plus 4, or a 3 plus 5, right? Those are the numbers. What does that mean? That means when I do the biopsy and I send it to the pathology, right, who reads those biopsies, they put it under the microscope and they look at it, okay? And they say, okay, what cancer is in here? What is the most common type of cancer? If the common type of cancer they see, it looks nasty, they say it's a 5. If they say, you know what, it's not that nasty, it looks almost normal, almost no cancer, they'll call it a 3. And in the middle, they call it a 4. So that when they look under the microscope, they say, okay, so what's the most common pattern of cancer I see? Oh, I see a 3. It's almost normal. Okay, what is the second most common pattern? Oh, it's also not concerning to me. So it's another 3. So you get a 3 plus 3 equals 6. So that's what the number comes from. Another patient, which I'm hoping, no one in this room will have it, I look under the microscope and I say, boy, it looks aggressive. The most common pattern is a 5. And the second most common pattern, so-so, it's a 4. So then you get a Gleason, 5 plus 4 equals 9. So different cancers mean different things. Why is that important? Because today, and for the last few years, if you are diagnosed with a good prostate cancer tumor, we call that low risk or good risk prostate cancer. You know what the best treatment for that patient is? Active surveillance. Don't touch it. We keep seeing you, but we don't do surgery, we don't do radiation, we don't do anything. We watch it. That's the best, what we should be offering. Now, a lot of people don't know that because, well, if I don't know that, I'm going to get treatment, right? It's like, doctor, I have cancer. The cancer word is in here. Take it out. Do something about it, right? So it's important for us to know that for certain types of cancers, they're not going to bug you. They're not going to bother you. We'll watch them. At 10 years, more than half of the people didn't need anything for that cancer. Can you imagine? 10 years later. We have that study, that data very clear. But what happens is, when we are talking to you and say, well, I'm concerned, if I don't know enough, I'm not comfortable telling you about who are the patients for active surveillance, then we'll end up treating you for something that you probably wouldn't need. So it's important to know that the cancers are different. By the way, there are only 2 treatments that cure cancer, prostate cancer in the world. One is surgery, and the other one is radiation with or without hormones. And I have to tell you a little bit about the hormones because it's something that people ask all the time and is an important point. But before I really wanted to break down to say not all cancers need treatment. Not all cancers need surgery, not all cancers need radiation and hormones, and that's a very, very important point. So if you have a low-risk prostate cancer, if a doctor, oh, no, it's better to take it out. Do I have low risk? Yes. Okay, let me find someone to talk about this in the right way. So this is very important to know that. Active surveillance is the standard of care. Some people, because they don't feel comfortable about having something, are looking for other options. So sometimes they burn it, sometimes they get cryoablation, which is kind of you freeze it. Some people, some people get seeds, which is different kind of radiation. But remember what I said. Low-risk prostate cancer, active surveillance is the recommended. What is what you should be doing. Okay. And then for the other cases, we will debate whether it's a patient for surgery or is the patient for radiation, with or without hormones. And before I stop, and I'll ask you all the questions that you might have, I really want to spend a little bit of time telling you about the importance of hormones in prostate cancer, because we talked about it all the time, and it's an idea, and it's a very sensitive topic, and a lot of us get scared about it. So what is that? Okay. So testosterone, men have testosterone. Women have very little, very tiny amounts of testosterone. We usually say women don't have testosterone. Okay, but men do. Okay. And the normal, it depends by age. It kind of goes down over time. In general, 400, 500, 600, that's about the number you can think, right? Some people 200, 300. Okay. Testosterone helps the prostate cancer cells to replicate. So we found out a long time ago, in the 40s, 1940s, we found out that if you get rid of testosterone, you get your cancer, you put your cancer to sleep. You don't cure anybody. You cannot kill those cells, but you put them asleep for a long time. So getting rid of testosterone is actually known as castration, which is a word that scares a lot of us, right? Castration. I inhibit testosterone, I bring testosterone down, right? And what happens? I will have symptoms like I'm going through menopause. Same thing. Hot flashes, night sweats, bone loss, muscle loss, weight gain. Two important ones for men, erectile dysfunction, lack of libido, right? Why? Because I don't have testosterone levels in my body. How do I do that? I do that in 3 ways. I can remove my testes, that's what we know, and that's the dramatic thought process that we have with castration. That's definitive. I just do surgery once. Okay. Most of the times we don't do that, by the way. I can do shots. I do a shot, and I can inhibit my testosterone for a number of times, for a month, for 6 months, for 3 months, for how long the shot lasts. I can also do a pill. I do a pill, and I lower testosterone. As long as I take the pill, the testosterone is going to be low. Why is that important? Well, because remember I told you that testosterone feeds the prostate cancer. That's how we say that. If I get rid of testosterone, then the cancer is looking for the fuel. Oh my God, I don't see fuel here. I don't see testosterone around me. So we'll go asleep. It will go dormant for a long time. Okay? Virtually all prostate cancer tumors are sensitive to testosterone. So if I get rid of it, even if it's for 6 months, the tumor is going to go to sleep for sure. And the reason why we do it with radiation is because it helps the radiation to kill better, to kill more. That's why we do it combined. But castration is a word that, that is very important for men because, number one, they don't go women. Low testosterone doesn't mean I have feminine hormones. Feminine hormones are things like estrogen, progesterone, etc. So when we go under castration, we don't become women. That's a very important point. But it is true that with low testosterone, I will feel the low testosterone in my body. I'm going to put up some weight. I might have some emotional changes, but the 2 most common questions are about, fatigue is also true. The most common ones are always sexual dysfunction or lack of libido, right? Because of the testosterone plays a big role into that. So some options are temporary, as I mentioned, for X amount of time. Other options are definitive, like the surgery I mentioned, okay? These days, over 98% of men, if you exclude the VAs, go with medical treatment for hormones. And I'll tell you, hormones are so important that they are used for localized prostate cancer. They are used when the cancer comes back, but you don't have cancer seen in the scans. You just see a rising PSA. And they also used in the metastatic disease. And I should have said, when we see metastatic cases, that means stage 4 disease. That means spots in other places of the body. The good news, even in those cases, we can control the disease for a very a long number, a big period of time, many years. So it's not like some other cancers, unfortunately, when we found out stage 4, right? Unfortunately, some cancers, we cannot control the cancer for more than a year, for example, or a year and a half in some cases, right? In prostate cancer, there's always options that we have available, even in the more advanced cases. Now, we don't want that, right? We want to find out the cases exactly early on, because that's when we can cure them. Meaning cure means we get rid of it. But I just want you to have an idea of how we think of the different options from the very localized cases to the more advanced cases. Make sense? So we talked about a little bit today about the stats, what do we expect, why we talked about this, but probably at every household we have this conversation at some point. We talked a little bit about the signs and symptoms that we should, oh my God, I need to bring this up for my primary care, for my family doctor, or urology for those of you who already have them, right? We talked a little bit about what is cancer, what does that mean, invading just the prostate, what tests do we do to find out what's going on, and then we talked about a little bit about how do we treat it, right? We talked surgery, radiation, hormones, and where hormones are. So that's kind of what I had in my mind that it would be helpful for us, but I'm happy to expand on any of these points or others if you'd like me to. So happy to take any questions, and thank you for being here with us today.
Why is it that seeds are not effective?
So the question is, why is not seeds effective? Okay, so let me just break down what seeds mean for the group. So seeds is a special form of radiation therapy. So each seed that we get in, and it depends on where's the cancer inside the prostate, the physicist and the radiation oncology team calculates how many seeds you need to treat that prostate. And the way it works is quite simple. You get the seeds close to that cancer spot, to that nodule, and then the seeds, because they release radiation, they can kill that spot. Okay. For localized prostate cancer, when you don't have spots in different places of the prostate gland, the walnut gland, it's only one spot, sometimes we do consider seeds as a good option. So it's not always bad, it's not always good. So when you have one spot, you can put the seeds there, and the seeds are around that nodule, that's a good idea. What happens sometimes is, when you have a large tumor inside the prostate, it's very difficult for you to treat the entire cancer with all the seeds, because you gotta have a lot of them in the prostate, and the more you get them, the more likely is for you to start having a little bit of radiation, messing up with your organs that are not prostate. For example, the bladder, the urethra, right, and the rectum. So the more radiation that you get, that you need to get there, the more likely are you to have other side effects. And there's a little bit of other things that can happen with the seeds. The seeds can leave the organ. In other words, when you put the seeds, and they stay there, you never remove them, by the way. I should have said that, right? You see them. If you get, you got seeds 10 years ago, and I do a scan on you, I'll see your seeds. Because they are, I can see them in the scan, okay? But it's not common, but it can happen. Sometimes one or two can actually leave and go to a different place. So seeds are appropriate when you have a well-defined, relatively small nodule that you want to treat, meaning you are in control, you want to put the seeds around that place. And there's healthy tissue is far from where that is. But when you have multiple sites, large tumor, that's when the seeds are probably not a good idea. Now, of course, it's not up to you to say, I want this. You can ask, how about this treatment? But the thought process behind the care teams getting together between the cancer doctor and the radiation oncologist and the surgeon say, you know what, you might not be the ideal candidate for that for these reasons. Or, you know what, it's a good idea. We can actually do that. So I hope that answers your question.
Is freezing better than radiation?
Okay. So the question is freezing better than radiation. So all you're asking, which I'm assuming you have some knowledge about it, is about that. You're asking different ways of addressing a nodule in the prostate. So freezing is called cryoablation, is a form of freezing. It's a treatment that works nicely in the short term, but some of these treatments, we do not know what happens 20 and 30 years later. So it comes down to when we see a nodule and we know it's a good risk, some people go for freezing, but we would say, why? Don't touch it. It's as good as freezing. So active surveillance became relevant, more relevant in those cases of good risk or low risk prostate cancer. In the more advanced risk for prostate cancer, you want to get a treatment that we know we have the better data available to cure that individual. And in general, that is external beam radiation therapy and or surgery. So it's nothing wrong about the cryoablation, but we don't know enough for that amount of time, because we want a man under 50 to be cured from prostate cancer and not have to deal with it for the rest of his life. So he's going to live another 40 years, let's say, right? So we don't know what happens at 20 or 30 years, and that's why we recommend the gold standard in general is active surveillance, surgery, and external beam radiation with or without hormones. That doesn't mean the other options are not a good idea in certain cases, but it needs to have that needs to be explained and discussed well with the patient that is asking for those, if that makes sense. So I'm not destroying the idea, but I just want you to know how we think about things. I'm sorry?
Is there a 5-year period where you need to be checked? Once you,
Explain to me what you mean by a 5-year period to be checked.
well, you every 6 months you got to come back for like 5 years to be checked.
You're talking up after cryoablation? Any. Okay, good question. What do we do when we offer treatment to patients? How often do we see them, right? Like let's phrase your question like that. Is that fair? So, when we don't have disease in other places of the body, we just have disease in the prostate, PSA is remarkably helpful. That and special scans called PET scans. Okay. So, for the most part, we see these individuals, in general, if you have high risk or intermediate risk, we end up seeing them between every 3 months to every 6 months. And in general, that includes blood work to get PSA, to get the testosterone levels, and to see how you're doing. Some other cases, you're really not concerned about what might happen because you are unlikely to have bad news. We are able to see those patients every 6 months, twice a year. So it depends on the risk. It depends on the chances of the cancer coming back. If the chances of the cancer coming back are very low, you can relax and see the patients less often. And you live your life and just see the doctor twice a year or once a year. But if there's a chance of your cancer coming back that'll be higher, then you want to make sure you're on top of things. And in general, most of the patients I see, and I'll tell you why I do that, in general it's every 3 or every 6 months. Now, I haven't said that, I don't know if you heard from the introduction, but I am not a surgeon and I'm not a radiation oncologist. What does that mean? I'm a prostate kidney cancer guy. What that means? That means that a lot of people come to me and ask me, say, Dr. Rada, help me to decide, should I do surgery? Should I do radiation? Should I do active surveillance? Because I'm not biased, right? I don't have skin in the game. In other words, I don't need to do surgery because I'm not a surgeon. I won't do them. I don't need to do radiation because I'm not a radiation oncologist. So people like sometimes to see the cancer doctor, the medical oncologist, to help them go through this. Hey, here are the pros, here are the cons. You know, here's what we think about this, here's what I think about that. I think this is a good idea. I think it's probably not as good idea. So sometimes we help making the decisions because we're not actually offering the treatment that you have to decide. So some people like that, right? So that's why sometimes the cancer doctors, like myself and others, get involved early on, right, at this stage. More questions? Yes?
Is the most common, like, first symptom the frequent urination or lack urination, or could it be something else like lower back pain or?
Right.
Something?
Yeah, great question. The most common symptom is we having trouble urinating. We call that urinary obstruction. Why? In general, not true, in general, most of the patients we see, and I should have said that we expect prostate cancer to happen more often in the 60s, right? That doesn't mean You know, I just saw a patient 39 yesterday, right, for example. So we do see very young men with prostate cancer, but when we talk about screening and so forth, we're talking about in the 50s to do that and having those conversations, sometimes in the high 40s. But in general, it's a disease in the 60s, 70s. Okay. The most common symptom for those men, because you already have a prostate that's a little bit enlarged, a lot of times you were squeezing the urethra, you're not urinating the way you used to. That is by far the most common. And sometimes the nodule is also putting pressure in the urethra. That means the urine doesn't pass as well as before. That's the most common symptom. When you have back pain, you should not have back pain. Well, maybe you have for other reasons, but because of prostate cancer, unless you have cancer in a place that is giving you pain, right? So automatically, prostate doesn't give you back pain. So if you have back pain because of prostate cancer, likely that's because of having a spot or more than one spot in the bones, usually the spine or ribs, right? So that's not the most common scenario. It might happen 1 out of 4 times, you know. But just to answer your question, definitely the lower urinary symptoms are the most common presentation of prostate cancer. Not just prostate cancer. If you have enlarged prostate and the prostate doesn't have cancer, but you can still have those symptoms. So don't get me wrong. I don't want to scare everybody, but I want to say if you have those, you should definitely seek help and, you know, and talk about that with your doctor. Absolutely, it's a good question.
All right, well, thank you.
All right. Thank you so much, guys. Have a good day. Thank you.